Hello, everyone, and welcome to Stanford Care's monthly community health talk series. My name is Pauline Tran, and I'm a first-year PA student here at Stanford. First of all, thank you so much for everyone for being here tonight. I'm so excited to welcome you to tonight's talk, which is co-sponsored by the Stanford Center for Asian Health Research and Education, also known as CARE, the Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. Today's talk is called Urinary Incontinence in Asian Women: Insights, Treatments, and Innovations, which explores how Asian women can support their health and well-being across key life stages, from the reproductive years and postpartum recovery to menopause and healthy aging. In this community-focused presentation, we have Dr. Bertha Chen here today, a Stanford urogynecologist and national leader in women's health. She'll share insights on pelvic floor changes and urinary incontinence, along with practical, evidence-based strategies to promote bladder health. Through a culturally informed lens, Dr. Chen will also discuss how culture, communication, and stigma can influence health behaviors in Asian women and why early care and open conversations are so important. Dr. Chen will also highlight treatment options ranging from lifestyle modifications and pelvic floor exercises to medical and surgical approaches as well. Dr. Bertha Chen is a professor of obstetrics and gynecology here at Stanford University School of Medicine, specializing in urogynecology and reconstructive pelvic surgery with a courtesy appointment in urology. She maintains a busy clinical practice caring for women with urinary incontinence and pelvic floor disorders and leads a multidisciplinary research program focused on regenerative therapies and voiding dysfunction. Her work is supported by the National Institutes of Health and the California Institute for Regenerative Medicine. Everyone, please welcome Dr. Bertha Chen.
Thank you very much, Pauline, for that lovely introduction. I'm delighted to be here. So let me share my screen. To the audience, thank you very much for being here. I'm delighted to share this next 40 minutes with you to bring to your attention a little information about urinary incontinence. Um, as Pauline said, I specialize in urogynecology, so I have a clinic where I care for women with this condition. Um, I want to kind of cover some of the topics, give you an outline of some of the topics that we are going to be talking about today. I'd like to review some of the pelvic anatomy and also kind of the changes that occur in the pelvic anatomy across the lifespan. We will be discussing the different types of urinary incontinence that present in women, in adult women. And I'll highlight some of the evidence-based approaches for urinary incontinence and some treatment options that include lifestyle habits, pelvic floor exercises, and medical and surgical options. And finally, we'll conclude by kind of giving you some data on how the culture and stigma might influence people's help-seeking behaviors in the health care system. So first of all, lifespan changes in women is actually quite varied due to our hormonal changes through different periods of our lives. As girls in the pre-pubertal stage, they actually don't have any hormonal activities. The ovaries are fairly silent, and so therefore there's not much going on in the body, and that's why you don't see the breast development or the menstruation. Once the young girl actually menstruates, then the woman the person enters into the reproductive stage of her lifespan, and in this period of time, in these decades, the ovaries are becoming active. They're ovulating and therefore secreting hormones that actually give us the breast development, the uterine development, as well as menstruation. And it allows, basically, this prepares the body to be able to have pregnancy and delivery. So these events are happening during these decades. And because of the hormonal changes and the pregnancy and delivery, the pelvis actually undergoes a lot of cyclic changes and injury, healing, and repair. So those kinds of events will set the stage for what happens next with menopause. But also with the injuries from delivery, women will start to experience urinary incontinence, most likely in the form of leakages with activity. And this tends to present after the first pregnancy or maybe after a couple of pregnancies. And this condition can stabilize over time or can get improved or actually worsen with the oncoming menopausal stage. This menopause and postmenopausal stage is characterized by basically the absence of ovarian ovulation. So you have gradual decline of the ovarian hormones that are produced by the ovaries. And with that, there's a lot of changes in the pelvic floor tissues, such as the connective tissue, as well as the smooth muscle cells. Um, and with the wear and tear that has now occurred over decades of doing physical activities and coughing or sneezing or things like that, these tissues are also experiencing the wear and tear changes, as well as the natural loss of muscle mass that occurs in our bodies as we age. So, with that kind of background, I'm going to pivot towards explain to you a little bit about the pelvic anatomy so that you can actually put the rest of my talk into context. So in the female pelvic anatomy, what you will see, this is a side view. Here's the abdomen and here's the buttock. You see the pubic bone here. The yellow, of course, is the bladder. And once you want to urinate, the urine comes out through the urethra, which is this kind of tube-like structure. Behind that is the vagina, which is it's the birth canal. And here's the uterus where the fetus grows for 9 months during the pregnancy. And behind the uterus, of course, is the anus connected to the rectum for bowel movements. And here's the coccyx of the spine. What I want you to pay attention to is this this red sheet that is depicted here. This is the pelvic floor muscles. So think of the pelvis as a big bowl that's basically holding all these organs as well as the intestine. But at the bottom of this big bowl is this sheet of red muscle. So I'll refer to this over and over again in this talk. So, in another view, when you turn this around, you were looking from the legs up, you can see the opening of the vagina, and here's the anus. The opening of the vagina, generally, the diameter is roughly about an inch, but during childbirth, as the baby comes through this canal, through this opening, it has to stretch to the size of the baby's body, which can be many times larger than this opening. And during that process of the baby going through this canal, a lot of the tissues are stretched, and if the delivery is traumatic or rapid, these tissues underneath, the muscles and the ligaments can all get sometimes ripped, and including the anal sphincter muscle. So this is how you can see why women after several childbirths can actually develop issues with their urinary function as well as their bowel function. So in this picture, we're depicting how the baby childbirth happens. You see this baby coming out, and you can see the vaginal opening is stretched maximally to accommodate the head and the body. So that's really, and here you can see the relationship. You've got the pubic symphysis, which is the bone, and you got the hard head of the baby. And so this bladder here is actually sandwiched between two hard objects. And so over time, there's this grinding that goes on, and so tissues can die and be macerated and injured there. On the other side, where the anus is, if the shoulders are coming out very quickly and kind of snaps out or something like that, that can rip this area, and that the injury can go all as far as the anal canal. So again, you can see as the baby comes through this canal here, this sheet of red muscle that forms the pelvic floor can be ripped and injured in many areas. And focusing on the Asian population, I'm going to give you data that kind of substantiates this. So there's a study by Shi et al. Who actually examined women in China. What this investigative group did was that they made MRI images of 10 women that had never had babies, and then another 10 women that just had their first baby. And what they saw was that 8 out of the 10 women that had a normal vaginal delivery, they saw these women actually had tears of the pelvic floor muscles. And so that means that this red sheet here was torn in some places and also detached from the bony places where it was attached to in some places. So most of these injuries will heal, luckily, but some will not heal perfectly. And if the woman continues to have more babies, these areas can get injured some more. And then with wear and tear, like daily activities, stretching, and all that in this area, the problem can then surface decades down the road. So now, with urinary incontinence is actually defined as a voluntary loss of urine. There are different types of urinary incontinence, and they're generally characterized by the symptoms that the woman is reporting. And in a little bit, after I present a couple of slides, you'll see the logic behind this. There are three subtypes. One of them, the most prevalent, common one is this what we call stress urinary incontinence. And roughly you can see from this pie graph that the dark red is the number of percentage of people that in the United States that actually report having the stress incontinence. And what this is leakage when a woman starts to cough or sneeze or laugh heavily or just has a jumping activity. Because what is happening there is that sudden kind of movement is pushing the urine out from the bladder. And a lot of people have that, about 50%. Another category is what we call urgency urinary incontinence, and this is also known as overactive bladder. People use it kind of interchangeably. And what happens here is that it's not associated with any activity. It's mostly the woman will report that, hey, well, I feel like I got to go to the bathroom, but I have to run. If I don't get there on time, I'm going to start leaking. And roughly 16% of the American women report having that kind of symptom alone. And then the rest, 34% of American women actually will experience a combination of these two. And generally speaking, the stress incontinence is kind of affects mostly young women because that usually kind of presents itself after a couple of deliveries. And the urgency incontinence and the mixed one tends to kind of be more prevalent in the older population. So how about the Asian, specifically the Asian communities? How common is urinary incontinence in Asian communities? It's actually quite common. Just to give you an idea as baseline, okay, the normal American women, we've actually studied this with with large national surveys that go on for years and years. In the United States, roughly 50% of adult women are reporting having some episodes of urinary incontinence. So very common in the United States. How about the Asian communities in the United States? There's a study here looking at the 1,800 women in the Chicago area. They're reporting about 29% of women having lower urinary tract symptoms. In our Bay Area alone, or like Northern California, this is a study looking at the Asian population that are seen in the Kaiser system, Northern California Kaiser system, and they are reporting that roughly 18% have stress urinary incontinence, and similar percentage have the overactive bladder or urge urinary incontinence. And this is kind of a table of their results. And you can see, interestingly, Asians in Northern America, Northern California, have a kind of slightly lower percentage of those presenting with stress and urge incontinence compared to Caucasians that are 15 to 10%. And so there is variability between different races. Um, and as far as other Asian communities that are US based, we also see in the reporting that South Asians that are living in the United States that come from families from India, Pakistan, and Sri Lanka, they have reported 37% of them report urinary incontinence in the past 7 days. Um, and the next three categories are Asian populations outside of the United States. In China, incontinence was estimated to be about 21%, 22% of the population. And in Korea, roughly anywhere from 36 to 63, with 63 being kind of the older group. You'll see from these numbers that generally the urinary incontinence tends to go up with older population. And then Singapore population, in the survey of a very large survey, they reported like 52% had urinary incontinence. So you can see the numbers vary based on their region in the globe, and also based on the heterogeneity of the Asian communities. But needless to say, it ranges anywhere from 20% all the way up to 63%. So quite common, just like the average, the general American population. So I'm going to go into a little bit of detail to kind of give you a kind of a framework to understand kind of these three urinary subtypes so you can have a better idea how to think about them. As I said just briefly before, that stress incontinence is really the symptom where a person is coughing and then they leak. If you look at what's happening, this is you see the normal bladder. It's filling up with urine, which is the yellow fluid. And generally, people don't leak because the urethra is closed. This urethra has a muscle that keeps it really tight. And also, there's a connective tissue and ligaments around it that keep it stable. But in people who have stress incontinence, where this area was damaged by childbirth, which is the most common cause, um, when they cough and there's extra forces pushing down on the bladder from the cough, this urethra it tends to open easily, and so and also the ligaments that are around there are not strong. So the combination of the two causes the urine to drip out essentially. Now, in the urgency urinary incontinence or overactive situation, actually what's occurring is actually different than the stress incontinence. You see, in the normal bladder, as the bladder fills with urine that's coming from the kidneys, it should be kind of quiet with the urethra closed. If someone has overactive bladder, what happens is that the muscle that's in the lining of the bladder actually starts to contract involuntarily. Normally, this contraction should only occur with our brains telling us, "Hey, we're on the toilet. You can go and you can urinate." But in this condition, the bladder just starts to contract like this, and because the contraction is all around the muscle of the wall, the force is quite strong, and it can push the urine out of the urethra, and you see a large amount of urine coming out. And so this is really distressing to most of the patients who have this condition. And you can see it in this cartoon. It's this typical, people are very distressed and they're just running like crazy to the bathroom because it's quite embarrassing to have this large amount of urine all suddenly coming out without control. And of course, the mixed incontinence is just the person that has both symptoms. So I'll start by talking about treatment options for stress urinary incontinence because the treatments are actually quite different. As you saw from this from the previous slide, there's different things that are happening. In this stress urinary incontinence, is the urethra that's actually not very strong and can't close very well. In the overactive bladder, it's the bladder itself that's kind of spasming. So the treatment options are different. We'll spend a little bit of time on the lifestyle changes, style changes, as well as physical therapy, because I know some of you had questions about that. So for women who have stress urinary incontinence, we lifestyle changes we usually recommend if to maintain weight within the normal range and lose weight if you're overweight. The reason for this is that we have very good, strong randomized clinical trials showing that in women who are overweight, who have stress incontinence, if they are put on a diet where they lose about 10% of their weight, they see significant improvement of their stress incontinence compared to people who did not lose the weight. So we actually have experimental data that shows that this recommendation does work. We recommend people to treat their constipation and so that they can stop straining with bowel movements. And this recommendation also there is based on there's robust data showing this. The thinking here, the hypothesis is that if you're pushing a lot, and if you're prone to constipation and there's decades of constipation, this continues to stretch out that red sheet of muscle at the pelvic floor that you saw in the previous cartoons, and that over time that wear and tear can really kind of cause weakness of that muscle. And similarly, avoid repeated heavy lifting activities because that also pushes and stretches that sheet of muscle. Now, smoking, for those who are smoking a lot, chronic smoking, quitting smoking is always good, but let me explain to you why it's important for people who have stress incontinence. There are two things that happen when you are a chronic smoker. One, you're likely to develop bronchitis, and so smokers tend to cough a lot. Every time you cough, you're actually pushing that sheet of red pelvic floor that you saw in the cartoon, and it's causing again more wear and tear. The second issue is that the nicotine in the smoke is actually very bad, damaging for the connective tissue all around your body. That's why smokers have skin changes. But in the pelvis, it actually causes degradation of the connective tissue there and therefore can weaken the pelvic floor. So, really a good idea to quit smoking. Okay, pelvic floor physical therapy. So, how is it done and why and all that? So, the way it's done is you kind of imagine that you're trying to pass gas and you have to squeeze the muscles that would prevent that gas from escaping from your rectum. That's kind of the motion. You would squeeze for 3 seconds and then relax for 3 seconds, and you do 10 repetitions 3 times per day, and just keep doing this. It takes a long time to work because you're kind of basically working that muscle, that red sheet that you saw in the cartoon. And if you do it for 3 to 6 months consistently, you're likely to see up to 70% improvement in your leakage episodes. Um, and you have to be you have to do it every day. And so for a lot of people, it's difficult to actually drive to a physical therapist or their insurances aren't covered and it's just logistically difficult. But now we have these devices that can help you do them at home. Um, so one of them, a simple technology is these vaginal cones. You can buy them on the internet. It's a kit that comes with various vaginal weights, actually. You just insert them like a tampon in the vagina, and you kind of can go around doing your household activities because if you're not contracting the pelvic floor muscle, that red sheet of muscle, it will fall out. So that's how you exercise that muscle, and you can increase in weight as when you go to the highest weight, you become an expert Kegel person. And then you would just continue using that 2 or 3 times a week to maintain that muscle strength. There are also these more fancy electronic devices called the Kegel trainers that you can use if you're more a visual person, you want to see things. So they usually come with some form of wand that you would insert in your vagina, and this is connected to your iPhone. And when you squeeze, the iPhone would show, or your smartphone would show this kind of what you're doing. And it usually they have programs of how many times to do it to keep you interested, and you would just keep doing them every day. Um, Another simple thing to do would be we can kind of insert a pessary, just a mechanical device. This one is a form of a ring with a little knob here. You can see it sits kind of in the vagina, but this knob actually compressing on the urethra, which actually narrows the outlet for the urine. So that's how it works. For this, we would have to see you and fit you for the right size and teach you how to take it out and put it in. And then you can just do it yourself at home and use it whenever you feel like you need it. Another very really safe option is this urethral bulking agent. And what is done here is it's an office procedure. It's very safe. We actually, there's no anesthesia. We put some numbing gel and we put in the cystoscope, which is the camera, and we put in a needle and inject this little bit of material in the urethra. And you can see by doing this, we're kind of narrowing the urethra so that less urine kind of leaks out. And this is in the exact same area that this little knob is right here. So it's kind of doing the same thing without having the knob. Um, it's very safe, but the problem is a lot of people kind of eventually don't move on to other treatments because there's a higher rate of failure because there's a limit as to how much we can inject into this space. Also, because the space allows the material to kind of leak out or spread out, the patient may need to come back a couple times for injections to kind of top off this filling. Um, uh, Aside from these kinds of non-surgical options, we're just now and the kind of the gold standard is really surgery for stress incontinence. Surgery is actually here again, it's a very small surgery. It's same day surgery. People can go home the same day. It does involve use of a tiny sliver of synthetic mesh, and usually patients can be up and around walking and kind of driving within the same a couple of days, and kind of doing regular sedentary activities. But we ask patients not to be doing excessive exercise like jogging or running for about 4 weeks. And the surgery is actually called, they all have a name with a sling at the end because they are, if you look at it, what the blue is the mesh, and so we're basically placing a little strip of mesh, kind of slinging the urethra. You see here, this one is called is slinging the urethra here. This one is slinging here, and this one too. They have different names based on how they're placed. And who gets one or the other really depends on the medical condition, their anatomy, and whether they've had surgeries before and things of that sort. But nevertheless, the concept is more or less the same. And what this sling does here is that it stabilizes the urethra. So when somebody's coughing quickly or jumping, the urethra is not moving all that much. And if you could recall, I was also saying, in addition to the muscle being weakened in the urethra, the support, the ligaments of this area are damaged from childbirth. And so this kind of tends to support and hold the urethra in place. And that's how it works. Um, so these sling procedures with mesh have been out since the 1990s, so we have good almost 30 years of experience. And the people have looked at it and followed the outcomes, and there's pretty much agreement in the field that more than 90% of women who are actually quite happy with the outcome in follow-up. That's studies that are up to 5 years after the placement of this sling. And even though the mesh scares everybody, and there was a time when the mesh had a bad name and lots of complications, this has been deemed to be safe by the FDA. During that time, the FDA went back and looked at all the data on the slings and found that the risk profile is different from how the slings were used when they were used for prolapse, which actually was the one that caused a lot of troubles. So this is the gold standard. And so now I'm going to shift gears to talking about treatments for overactive bladder. And you'll see that it's quite different from the treatments for stress incontinence. Stress incontinence, primarily the treatments are more to stabilize the urethra and to kind of pinch it off or narrow it. But overactive bladder treatments are fairly non-surgical. Um, Overactive bladder is a condition that we actually currently really don't have a handle as to what is causing it. It happens both in women and men, and it's associated with a lot of different risk factors. So right now we don't have a cure for it because of that, and you'll see that most of the treatment is really targeted at kind of minimizing the symptom that is causing the discomfort. So of course, lifestyle and behavioral changes are really great to do. Here, we're recommending patients to manage the fluid intake because if you think about it, whatever goes in, whatever you drink has to come out. And so, if you are those types of people who tend to drink 2 liters of fluid every day to maintain hydration, you're going to be urinating fairly frequently, and your kidneys are going to be putting out a lot of urine into the bladder, and you're going to feel the urgency to go. So we generally tell people to just moderate the intake, and if you feel like you need a kind of some gauge to know how hydrated you are or how dehydrated, I usually tell patients the best way to look at this is look at the color of the urine in your toilet in your and if it's really pale, almost the color of no color, you're probably overhydrated. Then you can cut back. If it's really dark yellow, like gold color, you probably need to hydrate some more. So you kind of want to get it to be kind of a lightish yellow, and then you'll be fine. There are foods that can irritate. Remember, overactive bladder, that's when the muscle of the bladder wall is starting to kind of contract, not the urethra. So you don't want to irritate the bladder. So you want to avoid bladder irritants. And we know caffeine irritates, and artificial sweeteners such as like Diet Coke or Diet Pepsi, those diet drinks are bladder irritants. And citrus juices such as lemon juice or grapefruit, and sometimes a lot of tomato juice can do that too. and alcohol as well. And alcohol also has a diuretic effect, so you have a double whammy with it. Now, weight loss, again, this appears is similar to stress incontinence. It does help with urinary incontinence, and weight loss only if you're overweight. If you have a normal weight, you don't need to do that. We don't really know how weight loss causes the overactive bladder to improve, but we do have quite a bit of data showing that weight loss correlates with reduction of symptoms. Um, Avoid on a regular schedule. This is kind of important with overactive bladder because what you don't want is for the bladder to get overstretched. Once you get overstretched with this condition, the bladder automatically will reflexively kind of squeeze, and then you kind of in that situation again. So you want to kind of preempt that, and we generally tell people maybe just put it on your iPhone or somebody your phone to ping you every 2 to 3 hours, and you just go, even though if you don't feel completely full that can actually decrease the accident episodes. And then again, manage constipation. But in this case, it's actually different from stress incontinence. You're not put in stress incontinence is the pushing and causing the stretching of the muscles, and that's the wear and tear. Here, we believe, and we don't have solid evidence, but we believe it's through another mechanism. It's because the rectum and the bladder kind of share commonalities in their nerves. So if the rectum is full of stool and irritated constantly with that, then these nerves communicate, and then the bladder will start to get irritated and show up with urinary incontinence type symptoms. So if you manage your constipation so you have regularity and stools are soft, you're going likely to reduce the overactive bladder symptoms. Now, physical therapy too works, but it's different than the stress incontinence physical therapy. Here, you're really trying to incorporate your brain to try to gain some kind of control over the bladder. And what we teach is this urge suppression strategies, which is like what we call the freeze and squeeze. So when you get that urgency, we ask you to concentrate and stop what you're doing and squeeze your muscles, doing a big Kegel exercise. So we send you to physical therapy to learn how to do that squeezing thing. And uh, and at the same time, you're actually using your brain to suppress and do that for a few seconds and to kind of get past that urgency kind of feeling so that it kind of the bladder is you basically are interrupting the bladder from doing that contraction. And bladder training is also helpful because bladder training is again using your brain to suppress that kind of urgency feeling. And here we ask you essentially when you get that urgency, you do this freeze and squeeze and wait a few seconds longer before you go void. And each time, after you kind of sequentially increase the amount of time that you wait, and that can actually help you decrease that urgency sensation. So you can see from this that we're targeting using the same tools, but addressing the different pathology. Um, Now, urge urinary incontinence, OAB, actually is a symptom that is very bothersome to patients because when the bladder gets activated, it's squeezing out a lot of urine. And so patients are very embarrassed. It's just basically you wet your entire underwear and clothes. And so it's very demoralizing. So for a lot of people, lifestyle changes and pelvic floor therapy probably just doesn't do the job. So we do have, they move on to medications. We have medications that help with this. Um, the older medications tend to have lots of side effects, and recently have been reported to have negative effects on cognitive function. So we tend these days not to prescribe these anymore, and we're switching patients to the newer medications which work on a different mechanism and are more bladder specific. These are mirabegron and vibegron. Um, and another option is Botox injection to bladder. So again, focusing on how do we relax this bladder muscle that's in the wall of the bladder. Botox works by relaxing the muscle. That's how it works for you cosmetically. It reduces wrinkles because your muscles aren't like squeezing. This is an office procedure. We go in with a telescope kind of thing, and then we have a needle, and we're just doing several injections of Botox into the wall of the bladder. It takes 20 minutes to do. It's very fast, and we don't actually use anesthesia, so people can just drive home after the procedure. Um, it's approved by the FDA since 2011, so we have a decade of experience with this, and we have long-term data on the safety for chronic use. So I have a lot of patients that actually just come in and just gets this done. Every 6 to 10 months because that's how long it takes the Botox to wear off. So some people actually can come, the Botox effect can last as long as 12 months. So it just depends on the individual, but this is kind of the frequency. There are very few complications that we see. Occasionally, patients can get a urinary tract infection just from the injection, the manipulation. And very rarely people can have a transient kind of urinary retention for maybe a few weeks, but I've only seen a few days at most. So this is a very well tolerated option, um, but you do have to come in roughly twice a year. Now, for people who have very severe leakage with the overactive bladder, we often will do combination of all these things that I just talked about, lifestyle behavioral changes, physical therapy, sometimes medication, and sometimes combination of Botox with medication. So the new guidelines tell us that we can now do a combination if people need it. Now, there's a whole category of nerve stimulation therapies that actually work for this condition because here again, we're trying to control the signal that incites this kind of bladder muscle contraction. And this therapy is predicated on acupuncture therapy, surprisingly. And what is done is you see this foot here. So the we actually use an acupuncture needle to go into that nerve to touch the nerve, and the needle is attached to a little stimulator. And this stimulator sends a little bit of electricity and that goes straight into this leg nerve. And this leg nerve actually comes all the way up to the pelvis and then actually connects with the nerve that goes to the bladder. So it's stimulating the signal that goes to the muscle that is contracting. And by doing that, it prevents the muscle from spasming irregularly. Up to about 50 to 75% of patients who do this therapy will see improvement. But it's quite laborious. You have to come to the clinic to get this done. It's 30-minute sessions each time. It's once a week. You have to do 12 consecutive weeks. And then if it works after those 12 weeks, you have to come back every 4 to 6 weeks to maintain that kind of stimulatory effect. So as you can see, it's not very well adopted by patients because it's really difficult to follow that regimen and come to the clinic so frequently. But I'm excited to report some new innovations. Just the last 3 years, the FDA has approved um, two implantable tibial neuromodulation devices. And this is also similar to this acupuncture treatment, but you can actually do this stimulation at home. You don't have to actually come to the clinic. Let me just show you. Oops, sorry. One of them is this one is it's called Revi, and what we do is actually there's a tiny titanium rod. It's the same metal that goes into your hip implants. We actually implanted next to the nerve under the skin. And once it's healed, you would put on strap this Velcro kind of stimulator on, and you turn it on, and it kind of sends the electricity or the stimulation through the skin onto this metal piece, and then stimulates the nerve. And so you can just wear this 30 minutes a day or 30 minutes once a week in your home while you're doing your activities at home, and you never have to come to the clinic. The other one that was recently approved is this one, Altiva, and this one's a little bit bigger because it actually contains the battery in here, and you would put it here, implanted under skin and the ankle as well. So uh, the Revy here, you can actually change the batteries whenever you want to when the battery dies off because it's an external device. Whereas this, you don't have to do this Velcro kind of anklet or whatever, but you do have to undergo a procedure to have the batteries replaced every whenever the battery dies. So there's good and bad for each of them, and it kind of the person has to decide with the physician what works best. But the nice thing is that you don't have to keep coming back to the clinic, and this can be done at home. Now, the oldest of the nerve stimulation therapies is this sacral neuromodulation. This has been around for decades. Um, Here, we actually use a pacemaker stimulator. It's the same technology as the pacemaker for the heart. And the pacemaker is kind of tucked in here, and the wire goes to this nerve from the sacrum, the S3 nerve here. The beauty of this is that it's here, it hits this area before the nerve kind of divides in the lower pelvis, because this nerve, one branch will go control the bladder, the other branch actually goes and controls the rectum. So because of that, this device is actually FDA approved for bladder incontinence as well as fecal incontinence. So for patients who have both, we tend to recommend this. But this is more involved in putting in and out, and in previous years it was not very well received because a lot they weren't MRI compatible, and patients were concerned that they would need MRIs in the future for orthopedic issues. But now the innovation here is that these devices have improved, and newer devices are compatible with MRI, and also the battery requirement is really improved. Now, before it was just every year or so, or every 2 years, but or 5 years. Now it can go all the way up to 15 years. So we're seeing a lot more people kind of adapting into the kind of embracing this modality. Um, so you can see there's a lot of treatment options for overactive bladder, and there is innovation that has occurred over the years. And this is actually a really nice development that for me, who has been treating patients for decades in this area. But there is one major impediment for people actually getting better. And this is what happens. It's this social kind of uh, uh, and stigma, these social kind of issues that and stigma that kind of limits Asian women from getting to the care that they need. And this is happening not just in America, but China too. So in these two studies that I have here, one is a survey done in China where they have national health care, so everyone can have access to care. Only 20, they found only 25% of women, Chinese women, actually consult a physician about the incontinence. Here in Northern America, this is a population that goes to Kaiser with Kaiser insurance, and they ought to actually have also equal access to this type of care. They found similar low rates of utilization. So these studies actually kind of are also try to tease out why Asian women were not actually going to get care. So I'm going to talk to you a lot about a couple of things that they found that might be the cause. First, there's lack of knowledge about urinary incontinence. And that is true. This is why I am here and just delighted to be here to tell you a little bit more about this because I feel that the more people understand this condition and know that their treatments are more likely to come to us. Because if the patients are not coming to us, no matter how good our technology is, we are not able to take care of the problem. Um, there are also negative attitudes about these treatments. People feel that they're too risky or too dangerous, or there's some sort of level of anxiety about these treatments. And here again, I think education is going to help a lot. Um, Amongst the different Asian communities from different countries, there's also this kind of uh, common view that urinary incontinence is a natural outcome of birthing and aging. Now, while that there is some truth to that, they don't know that there are actually treatments that can actually make it better. So, but most people tend to think, well, this is a natural outcome. I can just have to live, just have to live with it. There's also people expressed concerns about negative reactions associated with disclosure of urinary incontinence. And what we mean by this is that the patient is anxious about other people knowing that she has incontinence, like, for example, friends or family, uh, due to the embarrassment. But also the healthcare team knowing about the incontinence because they're afraid of kind of biases that might be developed from the doctors or the nurses caring for her. So this is an area that we also need to really work on to break these barriers. And the stigma, they found that the stigma associated with urinary incontinence is actually higher than the stigma for diseases such as depression and cancer. I'm Asian and I know depression, there's a lot of stigma in my culture from due to in patients who have depression. But it turns out that the stigma associated with urinary incontinence is actually higher than this. So that's a very that's a finding that I wasn't expecting and I found it in researching for this talk. So the social rejection kind of was associated with then social isolation and internalization of the shame, and all these things actually negatively affected the attitudes that patients had towards urinary treatment. So this is all super complex, and there are many areas that we need to conquer to kind of get our patients comfortable coming to us. And on top of that, there's cultural onlays about how families deal with this. For example, the strong culture of Confucius teachings that this has to be handled by the family rather than by the individual further adds to the barriers. So why is reducing stigma about this in Asian communities? Why does it matter? So I think it's really, really important. While we have all these treatments that we can offer patients, we need to get them to us. And it matters because by reducing these stigmas, we can encourage help-seeking behavior in our patients, improve their quality of care by doing so, and this also helps reduce the isolation and social marginalization. And importantly, it ensures better healthcare access because it teaches the healthcare team, the physicians and the nurses to let go of their biases, their own biases about women with urinary incontinence. So this is why it's so important to address this. So with that, I am going to leave some time for questions. And here are some resources that you can all access. A lot of the information you can find in the Voices for PDF and in this kind of link, which is actually embedded in the augs.org link. And you will also see these fact sheets that explains these conditions in kind of very understandable language. And a lot of the diagrams that I have in this talk are from there. Thank you very much for your attention.